this week on the BackTable Podcast.
But certainly, there's nothing unique about the concept of mastering your tools, your access, your tissue handling, and your anatomy. And from the EMIGS course, right? And, when you watch Dr. Milad get super excited about an electrosurgery pencil, and, what he's gotten into is the weeds of the tools. To know that tool inside and out, the way it's supposed to work, all its parameters for use. Is it the appropriate tool for the scenario? And recognizing we have so many tools, that's a lifetime of learning.
Hello, everyone, and welcome to the BackTable OBGYN Podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got another great guest here today. Today I've got Dr. Arpit Davé. He is an assistant professor in the Department of Obstetrics and Gynecology, Division of Minimally Invasive Gynecologic Surgery at Penn State College of Medicine, and is the Associate Program Director of the Fellowship in Minimally Invasive Gynecologic Surgery at Penn State Health, Milton Hershey Medical Center. Arpit, how'd I do?
You nailed it.
If you can tell, I probably didn't practice that one enough. But Arpit, we're happy to have you here today. And it's something that I personally am very interested in, and I'm going to guess that our listeners are as well. We're going to talk about teaching trainees how to learn about surgery. And when we talked about coming onto the show, you said you wanted to talk about teaching trainees how to learn surgery, not teaching trainees surgery, but teaching trainees how to learn about surgery. So I'm excited to get into this. But before we get into the meat of the show, what we like to do is let our listeners learn a little bit about our guests. So talk to us about you and how you got to where you are in your current position.
Well, Mark, first, thanks so much for the opportunity to be on the BackTable OBGYN podcast. I'm a huge fan of the show and have listened to all the episodes. And so it's really cool to get to take part in this experience with you. I remember our conversation at SGS really well about this and the difference between teaching trainees how to operate and how to learn how to operate. And so it's exciting to have this conversation. I'll first start by saying I'm happy to introduce myself, but I think I should probably put first the real experts in this who come before me. I am certainly not the world's greatest expert in teaching people how to learn about surgery, but I learned from the masters, and I just want to sort of put those people out there. We're going to talk about a lot of them during this show today because their names need to be heard too as people that other educators can go to learn from as well. Me, on the other hand, well, I'm a Central Texas boy. I grew up in College Station, Texas, which is a university town where Texas A&M University is. And I grew up as the child of two physician immigrants. My parents have the American dream story, moving to the United States in 1974. They did residency in Philadelphia, Pennsylvania, and then kind of moved on to Indianapolis for some fellowships, and then hung out their shingle and practiced medicine in Bryan, Texas, in the middle of Central Texas until about 3 weeks ago when they finally retired after 43 years together in practice, which is really wild to think about. I grew up there and I went to high school there and ultimately ended up going to college in Houston at Rice University. I was a student of Dr. Vivian Ho, who is still probably the professor who, of course, unbeknownst to her, because she probably doesn't remember me at all, I was abjectly a mediocre student of hers, but really inspired me to go into medicine further and really to focus on, to look at OBGYN as a possible career. I remember a lecture of Dr. Ho's where she talked about this idea that giving women control of the size of their families is a key element of raising developing countries into developed world status. And while a lot of that terminology has changed in the modern day about how we speak about this particular topic, this idea that women's health is the center point of societal development really stuck with me. And as I went through medical school at UT Southwestern in Dallas, I fell in love with OBGYN sort of surprisingly. I sort of thought I might do something else and ultimately found that it was a field that I could wrap my head around and really fit the service ethos that my parents had instilled in me. But outside of the world of medicine, I'm an avid traveler. I'm a devoted husband. I'm a longtime teacher. I've taught in some form or fashion throughout various stages of my life. I used to teach SAT prep courses for Kaplan and MCAT courses. And, even when I was in residency and private practice, I always looked for opportunities to teach anybody who was willing to try and learn something, because I recognized it was one of the ways that I also became a master of content.
That's what they always say. If you can't teach it, you don't know it.
That's right. Yeah, I would agree with that.
I think that's one of the main reasons why I've stayed in academic medicine is students and residents absolutely keep me on my toes and keep me honest. And I think in many ways keeps me from practicing medicine today the same way I did when I finished my training. So maybe it's a little bit selfish in some way as well. But no, I think there's a huge part of how we get better is to make sure that we are continuing to try to teach in that way too. So I know I definitely get that.
Yeah. And, we have a clinical practice and we have an educational mission and we have a research mission as well. And, there's sort of that weird saying of those who can do and those who can't teach. I don't think that's true at all. The question of whether I'm a better doer or a better teacher is something I'm only going to know in retrospect when I look over my career. And I hope that I did a lot in both. But, as they always say, I stand on the shoulders of giants, and I hope that I can put my trainees a little bit higher so they can see a little bit further.
Well, no, I have no doubt that's the case in anywhere that you've been, the passion that you have for teaching. And education is evident. I think that's something that many of us, I guess I won't speak for anyone else. I like to teach, but as I have been out in my attending practice, as I get more responsibilities and more titles and wear more hats, I'm being pulled in multiple directions. And so this is something that when I was new and fresh out and I wasn't as busy as I wanted to be and I wasn't getting those referrals that I thought I needed, well, that was more downtime to sit and get to know the learners and spend more time in the OR working through things. And now I'm like, well, I've got to get this 3 cases done and got to do these 2 things. And I've got a meeting at 4:30 and, life becomes busy. And so learning how to do it and learning how to do it well, teaching is a skill. It's something that many of us do well. Some of us, like me, need to learn how to do better. And so I'm excited you're here. What was your sort of interest specifically in surgical education? Where'd that come from?
Gosh, I became interested in education in general because to me, it's really all there is. We commit to being lifelong learners and we chose a specialty that has surgery at its core. So there was this overarching problem of this growing need in an environment of declining surgical volume. And that was really obvious to me when I was a medical student. Frankly, as far as I can tell, it hasn't improved since. Case numbers have always been sort of a running joke, right? Because the target is not to be below the 10th percentile, but by definition, somebody's always below. And so if the overall numbers keep going down, it doesn't matter how low the numbers are. If you just keep looking at percentiles, if our total actual N is really low, being above the 10th percentile may not mean as much as we like to think it means. Absolutely. And not only that, we also are, we're taking, just using hysterectomy as the prime example, we're taking a surgery that used to be done 1, maybe 2 ways, and now doing it 1, 2, 3, 4 ways, and still trying to ensure a modicum of competency among our trainees. And I think that there was a time in which paradigms like see one, do one, teach one worked because you were really you had the opportunity to see 30 of one type, do 30 of another type, and then teach 30 of them, and you just don't have that opportunity. And so it behooves us as educators to find ways to maximize the experiences that create not just skill in a particular procedure, but rather a general framework of understanding surgical knowledge that you can then add pieces onto as you begin to develop as a surgeon. And I do think that to the credit of true experts like Dr. Kara King, who have implemented a tracking program at Cleveland Clinic, they're really sort of taking this idea at face value that not every trainee is going to end up at the same position of competency at the residency. There just isn't enough volume for that. So how are we going to maximize that ability? Some people may choose tracking like Dr. King has. I had a really good conversation with Dr. Magrina at AAGL. And one of the things that he talks about is this idea that we should be trying to find medical students who are interested in surgery and tracking them into surgical specialties from medical school. And I'm not going to pretend like I know the right way to do this, but I certainly think that we really should be rethinking some of these paradigms. And that's kind of how I realized I was going to get interested in education because I've always loved to teach. But this is a really unique challenge. How do we prepare the next generation of surgeons to adopt technologies that we've never seen before, to adopt procedural approaches that we haven't had experience with before? And that was something that Dr. Iglesias actually talked about at SGS when she gave her keynote, was this idea that 70-something% of what she does as a surgeon now, she didn't practice or learn in residency or fellowship. And so there's got to be a more durable course of learning that we can educate our trainees with. And, I have to thank Dr. George Wendell, who's now the president of ABOG. He was my med school clerkship director, and he was the one who actually told me as a medical student, you're going to face this problem of declining surgical training volume. If you're interested in surgery, you should pick a residency program that has as high a surgical volume as you can manage, but also has a high surgical volume among all the different routes of hysterectomy. And then he looked at me and he said, and you should pick a program that doesn't have a fellowship. And I thought that was really fascinating because, his implicit statement was, you're going to get to do more as a resident if you go to a program without a fellowship. And I love my residency program. I went to what was at the time Exempla St. Joseph, but is now Intermountain Health in Denver, Colorado. And he nailed it on the head with that recommendation.
It's interesting because when I was a resident, I knew I wanted to do MIGS. I mean, as a medical student, I was watching like very early videos that Arnie was putting out and things like that. But where I trained in residency, they basically said, you like minimally invasive surgery and laparoscopy and we don't care. And good luck. And I mean, they were nice about it and they were being funny about it, but it just wasn't something they were super interested in at the time. And so I definitely had to do a lot of figuring stuff out on my own. But I would say in hindsight, the residents where I was in fellowship got a very different experience than I did. But I think we didn't have onc, I guess to your point, we didn't have onc fellows and we did everything, like every bowel reanastomosis and resection, there was no one to give up that good part of the case. And so you want to have enough volume, you want to have enough in that program to where you can actually get your hands in there. But yeah, there's no question that when I went to fellowship and was rotating on the GYN onc rotation, I don't think they were used to somebody who had spent so much time basically acting like the junior onc fellow for 4 years. There was a weekend on call at Michigan in my MIGS fellowship, but they were like, hey, we're out of town. Can you be the onc coverage for the weekend? I'm like, what? I don't
got this.
Yeah. And we have,
yeah,
it was fine. But I had so much more exposure in residency than a lot of folks where there was an onc fellowship. No. So I think that's actually really interesting advice. And I think I'll have to think about that because it definitely made me a better surgeon. We were doing insane stuff. I mean, obviously not on our own with, attending, we were assisting attending. So I don't want anyone to think I was like out there doing crazy things on my own. But yeah, no, our volume and our experience, our hands-on tissue handling and all those things was absolutely inherently different without fellows around.
I don't think I want to create the impression that you shouldn't choose residency programs that have fellowships. I certainly think that's a pathway to fellowship as well. But I think recognizing that there's such heterogeneity in the training experience across the spectrum of OBGYN residency, it is critically important that we have reproducible frameworks by which we can teach trainees in any training environment how to acquire new surgical skills at any point in time along that spectrum. And the way I think about this is how my residency attending, Dr. Peter Schultze, used to talk about this. And I'll call him Pete because he asked me to call him Pete. But Pete says, when you finish residency, right, that should be the worst you ever are as a surgeon. And your mantra should be to improve as a surgeon from that point forward, which means you have to have a framework for being able to expand a skill set that you acquired. And that's the part where I think what I talk about when I talk about learn how to do surgery. That idea that you're not just learning the surgeries, but rather you're learning a framework to know how to do surgery that you can apply to surgeries you've never seen before. And then you have a platform upon which to then add new tools to your surgical arsenal to be able to do cases you've never done. And I will tell you that in private practice, and I went to private practice after I finished fellowship at Mayo Clinic in Scottsdale, and I went to Tucson, Arizona. And in private practice there, one of the things I noticed was that my contemporaries who were in practice out of general OBGYN residency, underwent this sort of slow and actually kind of painful to watch skills contraction as number one, the surgical volume just plummets after training. And then on top of that, you're trying to pick and choose surgeries to do in a busy clinical environment that's predominated by obstetrics. And all of a sudden, that 7-centimeter myomectomy that you felt okay with at the end of residency now seems like a bridge too far. And, one of the things I tried desperately to do was to tell my colleagues, look, I'm busy, but I want to come and do this case with you. Because if you feel like you want to stretch that skill set and you feel like the way that you're going to feel safe to do that is to have somebody who does feel comfortable doing that with you, then great, let's do it together. Because at the end of the day, 2 surgeons who can do myomectomy is better than 1 surgeon.
when you offered, how often were you getting folks actually taking you up on that? Because my experience is there are some surgeons who are like, you know what, that was great. I'm so glad we got to operate together. And like, you can see them wanting to get better. And then there's some who, not because they don't care, not because they're not good doctors, because I'm very lucky where I am. I'm surrounded by fantastic doctors, but not all of them want to be big, busy surgeons, right? And I think that's something that some of my colleagues, and not even folks that are at UK specifically, but who've just said, I think I'm done. I think I'm done doing big cases. Like I'm just busy as an obstetrician or busy doing whatever I'm doing. They're not doing a ton and having that moment where they just go, I think I'm done. But there's a lot of pride. There's a lot of like almost sadness in that decision for some folks. But I think that's something that a lot of people think about.
I think you're 100% right. And honestly, I think I met a whole bunch of OBGYNs during my board prep when I was in practice. And in that group of people, there were definitely sort of two genres of clinicians. There was the ones who really wanted to, include that advancing skill set of GYN surgery in their personal practice, and the ones who didn't. And ultimately, there's no value judgment there, right? There is enough important OBGYN work for all of us to do. And ultimately, whatever a colleague thinks is the best way to care for a patient is something that we're going to try to respect. And, my offer is just an offer. And quite a few of them said, it's okay. I'm just going to send this to you and have you take care of it. And then there were others who were like, no, let's do this. Let's grow together. Let's find ways to do more interesting and challenging cases so that I can be a better surgeon and you can be a better surgeon. And, we learn together.
Those are some of my most fun days.
Absolutely.
Where
no question.
You're in the OR with somebody else and it gets tough, but having that other person there, whether it's a junior partner, or whether it's, someone from a different specialty. Working through things with another person to me is like the best days in the OR, both as, and I'm not saying like I'm only teaching, like I learn more than I think whoever's in the OR with me. I love seeing how people do it differently, but that's something that you got to kind of be really curious about. And so how did you come to the sort of idea of teaching trainees how to learn about surgery? Where'd that come from? Was that something someone talked to you about? Is this something that you just sort of like, this idea developed over time from observation? Talk about that.
Yeah, you had admittedly given me some question prep for this conversation today, and I was thinking about that question in particular. And to be honest, I don't know that I know where it came from per se, but I can recall moments where I realized it was important. And one of them was, as I was leading residency, I recognized that there were certain skills that I had that were procedural skills. But when push came to shove, I realized I didn't feel like I understood what it took to then apply that skill to a situation I hadn't seen, or a more complicated version of a situation I had seen. And that was the moment where I realized, okay, either I realize that I'm content with what I can do here and I will work hard to maintain this, or I create some framework upon which I can grow that skill set and do so safely while working on real live patients. And that was where, when I started applying for fellowship in that third year of residency, I had already sort of begun to understand, wow, okay, I can get good at this type of hysterectomy, but how am I going to do the hysterectomies I haven't seen? How am I going to do the hysterectomies that my attendings won't let me do? And that's really where I began to seek out fellowship programs that could answer the question, how are you going to teach me how to learn to do surgery, more than just how are you going to learn to do advanced endo excisions, et cetera? And, I asked around ahead, actually, and there were really only a few programs that I thought really had a good answer for me on that. And I applied to those and I was lucky enough to match them. And that was where, recognizing that Mayo Clinic was one of those places that their goal wasn't necessarily to make me an expert at the end of my fellowship at every type of endo excision, et cetera. It was to create the knowledge base that I could use to then add on new surgical skills, no matter what the clinical practice was that I ended up in.
So who was there? Who'd you train with?
So at the time, the faculty members were Dr. Javier Magrina, Dr. Paul Magtibai, Dr. Chrissy Butler, and Dr. Jeff Cornella. And then while I was there as a fellow, Dr. Johnny Yee joined the faculty.
Yeah.
And then my senior fellow was Dr. Megan Wasson, and Dr. Wasson is still there, and she is now MIGS faculty. So that was my training crew. And
it's a pretty good crew.
It was. And I will say that I felt very fortunate that fellowship in particular had a lot of exposure to things like urogynecology and GYN oncology, because that served me well in my first clinical practice where, I joke that the second most common case on my case list from this small practice in West Tucson was colpochleasis, because there was so much unmanaged prolapse where I was. But ultimately, having colpochleasis wasn't a surgery I did a whole bunch of it in residency, nor did I do much of it in fellowship. But fellowship had given me the tools to be able to learn how to do colpochleasis on my own, how to take the information about colpochleasis from other sources, and to have the confidence in my understanding of vaginal anatomy, to know that I could look at the diagrams of colpochleasis, that I could look at the surgical videos of colpochleasis and reconstruct that surgery in my head, build the visualization of it, and then execute that surgical plan. And so even though I had probably seen 4 in residency and maybe 3 in fellowship, right, I did that number double in the first 8 months that I was in practice, or something absurd like that. I don't remember the exact numbers, but it was one of those moments where I realized, okay, I have the key components of that were what we'll talk about in a second, this idea of TATA. The key components of that were understanding my surgical tools, my access for the patient, my tissue handling, and my anatomy. Those were the things I learned in fellowship. And then the structure, the format of the surgery. I had the language from those pieces, but then the script of the surgery was something that I could write by observing other surgeons doing the same surgery, taking the best of what I thought were the techniques they had that matched my own surgical style that I had started to develop. And that's how I pieced it together little by little. And then I, having a learning plan for myself. All right, how am I going to take this piece of knowledge from this surgery, and what do I need to learn from this that'll take me to the next surgery and the next surgery that I want to do and the next surgery? And how can I take pieces from surgeries that are unrelated to a different surgery and make sure that I'm learning something to cross apply elsewhere?
But that's a lot like what, when we think about guys like Steve Jobs, right? A lot of these guys that we think of as great inventors were really innovators more than inventors, and they would take things that they saw here and there and put them together and sort of saw the vision of how things could be better using things that were out there. I mean, he didn't make the first music, MP3 player, right? But he didn't make the first computer, but he figured out all the things. And I, thinking about the hysteroscopic morcellator was a ortho tool, right? Wasn't that what they used to shave down meniscuses?
Still do.
Yeah. So, I think understanding our tools, it's happened a few times. I'm sure you've been in that situation where you look around the table and go, okay, I know what I need to do to get over this hill here. There isn't a tool that maybe is exactly what I need, but how can I use what I have to kind of get from point A to point B? And so to get over this wall. And so I think there's some creativity involved. But again, when you talk about, TATA, TATA, I think you're putting those things that some of us or many of us do, and you're formalizing, which I appreciate, because I also went somewhere where there wasn't another mixed surgeon. There wasn't anyone doing some of the really big cases that I was doing. And I was looking around going, well, there's no one who can help me. And there's cases that are tougher here than what I even saw in fellowship. And I trained at a great place with great attendings who taught me an immense amount from not just MIGS, but Urogyn and ONC and generalists. There were phenomenal surgeons as well. And so, but there was stuff that I saw, I was like, okay, I've never seen this. And you ask around and people go, oh, I've never seen that either. But they look to you and go, all right, that needs to get done. So talk about this formula. Is this something you created? This was just sort of you putting together this idea, this sort of stepwise approach to becoming better at learning?
Yeah, so I will say, I guess I can actually take credit for TATA as the acronym, but certainly there's nothing unique about the concept of mastering your tools, your access, your tissue handling, and your anatomy. And from the eMIGS course, right? And, when you watch Dr. Milad get super excited about an electrosurgery pencil, and, what he's gotten into is the weeds of the tools. To know that tool inside and out, the way it's supposed to work, all its parameters for use. Is it the appropriate tool for the scenario? And recognizing we have so many tools, that's a lifetime of learning. I mean, there's literally a lifetime of learning in just the tools we have on a D&C tree. I'm fairly certain. And so the idea behind this is really just formalizing this idea that you need to be thinking about all of these things throughout that surgical training, But interestingly, OBGYN residency sort of lends itself in sort of there's 4 pieces to this, and there are 4 aspects to this. There's 4 years of surgery. And so, in our MIGS rotation, we get to work with the interns and the 3rd year residents. And then I generally have one of our MIGS fellows with us as well. So the operating room is loaded with trainees. And one of my tasks as sort of essentially the conductor is not just to make sure the clinical outcome is good for that patient, but that also we've tried to achieve some educational goal for each of those trainees. And for me, this framework helps me keep goal-oriented about what my goals for each trainee are. If my intern picks up something about anatomy and access during the case, great. But I really want my trainee to become a master of some tool for that case. And so, I was just working with Dr. Abby Short, one of our fabulous interns, and having her do a deep dive on suture recently, really beginning to really get deep into the weeds about the differences between the types of sutures, why you pick certain types in certain clinical scenarios, what types of needles are valuable for certain uses. Now she looks at suture fundamentally differently than she did before. And now, interestingly, there are these very important questions that percolate to the top of her mind, which is, why do we do it that way? That doesn't make any sense for the type of suture we're using, right? And I think it's really fascinating. For example, we all learned something really interesting. I learned, for example, that dyed sutures have a tattooing effect that I didn't really know about. And my other faculty member learned that if you wrap a Vicryl and a PDS suture against each other and you pull, the one you think breaks first is not the one that breaks first. The Vicryl will break the PDS suture. And so even though PDS lasts longer, Vicryl has more tensile strength. And those are pieces of information that become valuable as you start to think about what suture I should use. And it is interesting to see that, as she now operates with attendings in labor and delivery, and they choose certain sutures for things like hysterotomy closure, she's now starting to think about that question. Is this the suture I would use? Based on what I know about the characteristics of this suture, why are we using that suture? And I think those are the really important questions that start to create a very deep knowledge about the tools in the armamentarium. And I have another intern who's going to do a deep dive on dilators. Why Pratt? Why Hank? Why Hagar? Why are they shaped differently? Why are some cuffed? Why are some not? Which one's perfect? I think those are fascinating. And honestly, I think the idea of mastery, whether it's the tools, the access to the abdomen or the vagina, the handling or the anatomy, these are the minimum set of knowledge you have to become a surgeon. That mastery is not a goal, it's a journey. And as you build the skills in each of those, you get to these unlock new surgical abilities, a new surgical complexities. And of course, if you're sort of mindful, thoughtful, and honest with yourself about that growth, you can grow safely in independent practice by leveraging each of those tools. And it is hard work. Planning out a learning path for stage 4 endometriosis, now that you're sort of doing it on your own in clinical practice, is something that requires a lot of forethought and planning. Where are the safest places to be able to practice the skills I need to enter the rectovaginal septum? How can I utilize my sacrocolpopexies that I'm doing as practice? What are the tools that I'm going to do to keep the distal sigmoid and the rectum safe as I practice this for the first time? And what do I know about tissue handling in this space that I can do? What do I know about my anatomy? Have I reviewed where all the nerves are? Do I know where all the vessels in the rectum are? Those are the pieces that give you that sense of confidence that you can proceed forward. And as you take that bite by bite, every surgeon takes different size bites, and that's totally fine. And that's the sort of sequential progression that you make. But without a generalizable set of knowledge, you really don't have the ability to compartmentalize the surgery into its component parts and then piece them together bit by bit.
I think it's sort of how I think about when you see a patient, they have a list of prior surgeries and medical issues and their uterus, their pathology looks a certain way on imaging, but there's this great unknown until you actually get in there and start looking. But there's that moment when I get the scope in and I go, okay, I can see here, see that. Okay, I'm done. Before I've made a single cut, before I've made a single move.
Totally.
I imagine it's what, a chess player, a good chess player, when they see the moves to checkmate, I go, okay, yeah, we're done. Other people in the room are learning as we go along, but I'm done. I understand how I get from here to there. This part is going to be a little bit of a challenge. We can do this, do that. I've got all the pieces, all the tools we've used. I know how to get there, and now it's just a matter of doing the work. But all that's done in my head beforehand because of all the pieces we've put together for every single step, all the different things, knowing what we have to do to get from point A to point B. That's one of those things that sort of visualization you talked about earlier.
Mm-hmm. And, I'll say that, being able to see that early in a case also opens up as an educator, it opens up the mental space, the cognitive space to be able to think about how to maximize learning for the trainees during any component of that surgery. And one of the places I think about this a lot is the question of tissue again. There is no amount of simulator that has yet been able to simulate the fidelity of real tissue. And you don't get enough pig labs and you don't get enough cadaveric labs to get good. So you have to do it on people. And that is the nature of training. And certainly there are people out there who object to the idea that we practice on them, but that is all we do. We're all in practice all day. And one of the things that's I figured out recently is that we can create sort of sandboxes of safety for trainees during certain cases for them to practice skills like tissue handling. And different trainees have different places where they can do this safely. But I think about my third and fourth year residents that I get to work with, who I'm really starting to try and get to think about careful tissue handling and how it varies in different parts of surgeries like hysterectomy. And, if my residents will say there's one thing I say, more than anything else, it's pull, dang it, pull. And I want them to pull on this tissue. And, salpingectomy is such a wonderful surgery to practice tissue handling because it's a tissue that if you mistreat it is quite easy to make bleed. But if you handle it correctly, feels like beautiful surgery because the mesosalpinx divides so beautifully when you have the right tissue handling and the right direction of countertraction. That's this zone of safety that I can get residents to practice in for one particular tissue. Creating zones of safety around the uterine vessels. One of the skills that residents panic about, I find sometimes, is this idea of how do I skeletonize the uterine vessels and how do I get those vessels totally isolated? And, creating a zone of safety for them by having, that uteromanipulator displacing the uterus cephalad and having those anterior and posterior leaves taken down. I tell them, look, take your bipolar and show me where you're going to divide these vessels, right? And they go, I'm going to divide them right above it. Great. You know where that vessel's supposed to be sealed and divided safe. Anything cephalad of that on the specimen side is free territory for you to practice because worst comes to worst, you lacerate the vein and inevitably they lacerate. That blood loss is going to be 5-10 milliliters at most because they're going to reach down, grab the vessel right where I told them their safety zone is, seal it, and they're done. And we create that safety zone for them that now they begin to, okay, what does it mean to pull this little wisp of tissue and cut it? What direction am I supposed to pull it? And I ask them those questions. What direction do you want to pull this tissue? How do you find that countertraction at 90 degrees to your direction of your incision to be able to make this work? And it is cognitively difficult work. And one of the things I have to tell the residents is, you are probably not going to do a whole hysterectomy with me for a while. But the things that you're going to practice on these hysterectomies, I expect you to take to every other hysterectomy that you get to do in anybody else's OR. And I think I'm starting to see some results, and I'm excited about that.
It's something that I think we all do. As you're saying this, I know there's moments like, the posterior leaf of the broad ligament, right? That's sweep, and pull on the posterior leaf and sweep everything towards the vessels. It's a very delicate little piece of tissue, and we want to sort of push. Once it's there and they see it, that the tissue's spread with no energy, nothing sharp, and they just go, there it is, when you're in the right plane. But thinking about it in terms of these terms, tools, access, tissue handling, anatomy, and focusing on each of those skills as they are appropriate for each step of the case and sort of compartmentalizing each, you said, like creating sandboxes for them to work. Okay, now we're going to work on this particular step. I'm going to show you this one skill. Now you play with that, see if you can get that. And then boom, next step, and kind of do the same thing. But to be able to formalize it in that way, I think allows those of us who do this to teach it in a way that shows them that they can develop those skills and use them throughout their ability to do those cases.
For sure. And I love finding new sandboxes. When we talk about the doing the peritoneal biopsies for the fellows and mobilizing that ureter, creating a sandbox in which, they can, open that Okabayashi space in that medial pararectal space, that moment where they figure out where they're supposed to make that first little buzz to get that ureter to separate from the medial leaf of the broad ligament. You do it for them a couple of times, and then you have them just work that line that you've started. And then they feel very confident, right? Like, okay, great. I've got to play in my little sandbox, but that's incremental. They started by first just making that linear incision through the peritoneum. Then they're working on just broadly opening that pararectal space. And each time that they increment, I'm documenting, I'm grabbing it on video and I'm showing it. We're debriefing this. And then we come back and give them a new challenge once they've stepped up to the plate. And every one of those little sandboxes we get to find gives them a safe space that they can practice a skill somewhere in the TATA realm, right? Whether it's tissue handling or whether it's exploration of anatomy. That's also, I find, very fulfilling as an educator too. It's sort of emotionally fabulous as well. As an educator, it's exciting to like try and look for new sandboxes for people to play in, right? For these trainees to play in. This idea that here's a safe space to practice a particular skill that I need you to develop. And here's how we're going to practice that motion, that action. And then we'll take it to a new place and execute it there.
Chopping up the hysterectomy into separate steps in ways that here's a section we're going to work on, and then the next time you can work on this section. It seems very overwhelming, and especially since everyone's just worried about, am I going to get to close the cuff? There's so many parts of that. Over time, each one of those steps is incredibly important, especially on the really hard ones. So like posterior relief of the broad, that's like a magical part of that case, especially if the anterior part is a disaster. You can just hop right over the uterines, push, spread, there's your pubocervical fascia. Doesn't matter what's anterior. That little triangle, that little white triangle, I'm home. It's over. And so watching them go, I did it, and then pushing that open. But each, compartmentalizing and just giving them, I like that term a lot. The sandboxes, we're going to play in this little area for a bit. We got to finish the case. The whole case is not a sandbox, but we're going to create little sandboxes, little playing areas where, and I know for our listeners who are not doctors, if there are any, no one's playing. This is all obviously like, we're working, we're progressing, we're doing it safely. But creating safe places to learn that can teach these skills that, because that's what we do. When, the first time you do a 1 kilo or 2 kilo uterus, you're going, okay, where's that? It's still the same stuff. Ultimately, I need to get to that view. How do I get there? Okay, so I'm going to do this before. That's like what you're saying, the learning how to learn. Okay, so now I can take what I've done before. I know that I have the skills to do this thing. It's just bigger, or it's just wider. And so what can I do to find that? What do I need to do to get back to that same thing? And so, each of those steps, creating little sandboxes. I like that term for teaching. And this is something that I definitely find myself struggling with in the OR with the residents, is figuring out where to teach them, where to give them that autonomy, because some of these cases are tough and we don't have fellows.
Absolutely. And I think there's a really fabulous book, which is not related to surgical skills at all. Making It Stick, or Make It Stick, is the name of the book. And one of the insights from that book is that there's only so much cognitive load that a trainee can take before the learning stops. And at that point, they just become rule followers. And there's no question that our trainees are very good at doing what we tell them to do, right? Hold here, push spread here, cut here. That's not really rich educational experience for them, because at that point, they're sort of just going through a set of motions that they're being instructed. And the sandbox concept, I think, is valuable because it also alleviates them of the responsibility of progressing the surgery through a certain part in a certain amount of time. And some people sandbox in terms of time, right? So you have 15 minutes to work, right? And that's one way of sandboxing. The other way of sandboxing that I use more frequently is the idea that I'm going to sandbox a task. We have to get through this task and this subsection of the hysterectomy, and that's what I want you to work on. After that, the rest of this is mine, or the rest of this goes to the fellow, or something like that. And it allows us to maximize their cognitive load. So it's not that it's easy. A lot of times they still come out feeling somewhat dissatisfied, but sometimes that sense of this is a struggle is actually the best form of learning. That's kind of one of those principles from that book.
I think it's also, there's an element of fatigue for those of us in faculty, who are doing it, and who are the attendings, who are responsible for the case too, because I do want to teach them. I do want to give them opportunities, but I think when I don't sort of chomp it up into little sandboxes, it's like, well, where's the opportunity? And sort of being able to do that. It really is enlightening to me. It's something that I'm thinking, how my brain is just kind of spinning a little bit. The wheels are turning and going, okay, this is what you're going to get to do. We'll give you this time, but then we got to get through the case, and it gives them an opportunity to feel. We do that with the cuff, I think, to a degree. It's sort of like easy to sandbox that, but also it's like, well, I'll do the corners, you do the cross, and then eventually you'll do the apex next, and then you'll do there's different parts of that too. But sandboxing and sort of giving them a place to do some work, and the next time you do a case with them, ideally they've gotten a little better at that, and we can add one more sandbox or expand their sandbox.
Some of the principles that I think are, we're getting into now is the the sort of psychometrics and educational theory. How do we measure this progress that the trainees have? Because ultimately I can leave them in the sandbox, but if I just put them in the same sandbox over and over and over again, they will get good at a particular task. And that's what we call massed learning or massed practice. And mass practice is the equivalent of, it is easy to learn, to cram your pharmacology for your med school exam by just reviewing the flashcards 1,000 times for the test. And then you nail the test and then you promptly forget everything. And that mass practice it feels very good because you're like, I got this. But it turns out that it doesn't result in durable learning. And so one technique that I use, though I will tell you I find difficult to measure, is what's called interleaving. And so I like to put the trainee in a particular sandbox, and then in my next opportunity, put them in a different sandbox. We're still practicing the same general sets of skills. Are you practicing your tissue handling? Are you thinking about your anatomy as you're working in this? Are you using that tool effectively? I'm putting these specific cognitive loads on them in different sandboxes. And I will tell you, I don't think they actually like it. It feels very hard, but I see it in their progress because I see that their respect for tissue begins to change in that they know where they can pull harder on things and they know where they can't pull as hard on things. And they know how to choose between cut and coag when they're dissecting tissue or cutting through. And I see those decisions get better every time. And I find those adult learning principles really fascinating because they really do work. But I will tell you that if I had to get satisfaction scores back from the residents, I probably would not score particularly well because it's hard work. But when they come through it on the other end, I think they see that they feel more confident with those individual steps of the hysterectomy, even though they came out maybe having done, in total 3.
You do get teaching scores from the residents though, don't you, ultimately, or no?
Oh, I absolutely get teaching scores. But, the teaching scores from the residents are, we use that New Innovations platform. I don't know if y'all use New Innovations, but the kinds of questions on New Innovations don't score me on how hard was I on them, and how long did I let them play in the sandbox? Or those aren't the questions I get scored on. So I get reasonably good scores, which I'm thankful for. But I think if you ask them questions specifically about how hard was it to work with Dr. Davé and how hard did he make you work in the sandbox, they would say I make him work pretty hard.
I would think that'd be a good thing though. I mean, I always joke about patient and learner satisfaction scores. Like it's like having a teenager satisfaction score. Like ask them when they're like in their 30s, what kind of parent I was, maybe not when they're 14 years old. But so I think we understand tools, tissue handling, anatomy. Explain, what does access mean in this? What is it? Simply just laparoscopic versus vaginal versus open? Is it just like, is that all access means to you or?
So yeah, access to me means for the pathology that I have at hand. And so when I think about access, I would say probably most basic is this idea of, do I use laparoscopically, vaginally, et cetera, right? But I think it's really clear that there's a value in having a certain technique that you've mastered. But there are clinical scenarios in where you should reasonably do something different. And having a control over all of those access techniques, whether it's varus entry, Hassan entry, whether it's open entry, vaginal entry, all of those things are really valuable. And I think about this referral I got recently where a patient had open cholecystectomy. She had had an open revision of a Roux-en-Y gastric bypass that had had an anastomotic. She had had a bowel obstruction with a midline vertical incision and then was sent to me for hysterectomy. And it was a referral to MIGS principally because the surgeon didn't know how to access this patient and felt that there was no good laparoscopic access. So this patient gets referred. There was this sort of aha moment among the various trainees that I sat with when I was like, well, how do we solve this? And, they're batting around the risks and benefits of Hassan entry versus varus needle entry. And I said, excuse me, we're doing a vag hyst for this patient. It dawns on them like, oh, right. If I understand all of my access, I have a mechanism by which I can do this surgery. And, I said, you know what, maybe we won't be able to do a vag hyst. This patient has no dissensus whatsoever. Maybe we're going to struggle. But what I can do is get into the posterior cul-de-sac. And what I can do is insufflate the abdomen through the posterior cul-de-sac. And I can get a scope in and find where my adhesions are, and then try and place a port under direct visualization through a space that I know is clean still. And that's the kind of creativity you get when you really start to think about access from the general perspective of what are all my routes available. And access requires knowledge of anatomy, a knowledge of tools. I mean, those are all parts of the access equation. But when I think of access, I also think about the question of, in addition to how to physically access a patient for surgery, I think about the question of should one do surgery? And I would say maybe harder than knowing what surgery to do for trainees is knowing when not to operate. And I think that's a lot of maturity that I gained in practice. And I definitely took a lot of big bites that were probably too big for me at the time. And because I had a good sense of safety and an exit strategy, I managed to leave most of the patients unscathed. But certainly it is, when I think of access, I think about this question of, I have all my tools available to me. That includes things like my MRI machine and my ultrasound and my physical exam. And what do those tell me about how to access this patient? How do I access this patient's pathology? I'm going to access it with an endometrial ablation. We're not going for hysterectomy. That's what I think about when I think of access.
I also think, and I like that. And I also think about, I think when we put our scope in the umbilicus and we have a number of instruments on the right or left side, don't forget we can use a suprapubic instrument. We can put the camera in the right lower quadrant. We can work at a different angle. We can use a 30-degree scope or, versus a 0 degree. And we have so many different ways we can look at this problem and go, well, I just can't see. Okay, so let's think about how we can look at this differently. What do we want to see? And how could we see it better than how we're seeing it now? And I think that's something that I think it takes a little bit of taking a step back and going, okay, just everybody pause for a second. Look at what we got. This is a puzzle. If we keep going the same way, we get stuck. How do we think of this puzzle a little differently? Which is ultimately what I loved about surgery. What I loved about doing complex GYN surgery was, I like doing puzzles. I like figuring things out. My son and my wife will always, do the mini crossword every day. There's stuff like that. You're always trying to just figure stuff out and riddles and things like that. But I feel like the tools, the access, tissue handling, anatomy is a great way to sort of systematically go through that process of okay, because I said this before on another show, most hard cases are not hard all the way through. I mean, those exist, but they're really, really rare. Mostly it's I know how to do this, and this. I get to this point and I'm like, okay, I don't know what to do. I know what to do if we get past this one part. I'm stuck here and now we all go, I call for help, do I open, whatever we decide we got to do. That's where I think using this little, going back to the sandbox and going, okay, how can I play with this, look at this, think about this in a different way? I think I know how to do this. I've learned other parts. I've played in other sandboxes that might give me different access. Like you said, whether it's a different space. Okay, midline is a mess because of our C-sections. Can I come in laterally? I know that space. Or I know that space. Let's see what we get. And then something opens and go, wait, boom, I see it now. Yeah, those are the moments where you go, okay, I'm home.
And as an educator, I would say one thing that I do that I wish I heard more educators do is say, I'm not entirely certain what happens next in this surgery, right? There will be moments in that posterior cul-de-sac where it's just totally frozen over. You're poking and prodding on the left, poking and prodding on the right. You're looking for just a millimeter of space to find. And I tell the fellows, I don't know where my access point. I'm looking for it. And then I start to talk out loud. What are the things I have to make sure? I need to make sure that this patient stays safe. What are my parameters for safety around this? How can I increase the safety for this patient while we do this? What do I know about my anatomy in this moment that I can exploit to my advantage? What are the surgeries I've watched and what techniques have I seen people do? And I think back to whenever I'm trying to work parallel to the rectum in a really bad frozen pelvis, I always think to myself, what would Dr. Summer Nahas do in her laparoscopic excisions of stage 4 endo? And how close she gets that ligature to the lateral surface of the sigmoid. I'm like, I would never in a million years think to go that close to the sigmoid, but today I'm going to have to because that's what this anatomy requires. And, I say those things out loud because I think it's important for the trainees to hear what the thought process is like of this puzzle solving.
It is definitely a lifelong learning experience. I've been doing this now, at least since graduating fellowship. This is year 12. I still feel like I have so much to learn. I'm glad I've progressed in the way I have. And I had to do some things where there wasn't anybody around. And so you want to be safe first, but you still have to progress. You can't just get frozen and stop and go, okay, well, this is what I'm going to do and refer everything else out. There's no one to refer to, but more importantly, you need to develop those skills. You got to get better and you got to do it in a safe framework. So I think whether this is the way that you as a surgeon are teaching trainees, whether this is how you're going to do it for yourself, I'm going to give myself this section to work on knowing it's safe and allow yourself to develop. And I think I did that too, watching videos Sukettu's videos were so good. Just so okay, this is the step. Okay, and then watch this one part and go, okay, I can do this. And then you do the case and go, I just did what he did. And then the next time you go, okay, now I got to do that. Like you said, give myself a little place to play today. We don't have to have an attending do that for us. We don't have to be the attendings to do that for our trainees. We can do that for ourselves too, I think is the last thing I would say from what you're saying. That's what I'm taking away is we don't forget we can do that for ourselves as well.
Absolutely. And I think that's the growth path after residency, that if we can instill this systematic approach to building surgical knowledge, then that's the way in which residency, the end of residency is the worst you're ever going to be as a surgeon. Because after that, if you have this habit in place of building upon this skills in an iterative fashion and planning out your learning, you absolutely can grow any surgical skill set that you want. And the truth is, my Urogyn skill set has atrophied, in part because I just don't do that much. Because I wanted to move my practice over to pelvic pain and endometriosis. That was where my passion was. And so I, created myself a learning plan, executed that learning plan using this TATA framework. And it was the mechanism by which I was able to start doing those cases on my own in an environment where I didn't have a lot of that. I feel like we should talk a little bit about how we sort of measure this progress, because this is all good and well, but ultimately, is this actually any better than what we were doing before? And that's sort of unclear unless we have some sort of mechanism by which we think about how to measure the way we try and educate our trainees. And I love all the work that's been done with OSATs and even FLS for all of its flaws and EMIGs for the, I think market improvement that it is. There's sort of a je ne sais quoi about this translation over the valley of simulation to live surgery that we're sort of trying to get our best approximation of. And I've been looking for some tools, and to this credit all goes to Dr. Veronica Lerner, who is sort of the maestra of this field.
Simulationista was one of our guests on the show. Yeah, she's amazing.
Right, absolutely. So she and I were having a good conversation at AAGL about this, and we were both talking about how the psychometrics of skills validation is very difficult to do, and what sorts of tools are available for this. And the first of one, she sort of turned me on to this idea of something called the goals framework. That was, I think, kind of probably back in the mid-early 2000s, Dr. Fried in working in general surgery, looking at this idea of, is there sort of a global rating scale that we can use intraoperatively to assess surgical needs? And then is there some sort of task-specific checklist for that surgery that we can measure, collect that data, and be able to track each trainee's progression through that particular skill set? I think the idea of measurement is really important, and the ability to do some sort of global assessment of someone's intraoperative performance has been historically difficult because there's really only one validator at any point in time during a surgical case, typically the attending who's busy doing something else. And with our increased ability to do things like recording of surgeries, now we have this opportunity to have independent raters evaluate the surgical skills of a particular trainee on a particular task. And the organization of that data has been particularly difficult because it's sort of hard to put all of those pieces in one system that you can use to effectively collate and assess all in one. And I was really excited from AEGL to see some of the work that's being done by Hologic and its partner company that they work with called Innovus. And I think they have this plan to send out laparoscopic box trainers with sort of with this AR, this augmented reality layer, plus a hysteroscopic simulator. But the software platform that comes with it has the ability to take live surgical video and to do the same kind of procedural identification, tagging of a surgical video for a particular skill, and then create an easy to access format for it so that an attending, for example, who's working with a trainee in a surgery can quickly look at the list of tasks that trainee has performed, watch their most recent example of it, and then decide what the next educational objective for that trainee and that next educational opportunity will be.
I think Theater does something similar. There's a couple of companies that do use AI software to watch you operate and will tell you spend a little more time on the ureter, you're futzing around on the bladder, things like that maybe that's the next thing. And I was going to ask you that later, but you sort of answered it before I even got to ask, which is what does the future hold? And I think your sandboxing and the TATA, the way that we can sort of put a framework around this process is a great way to think about how to learn. And I think it's exciting to think about how we can sort of test these things out, because like you said, it's sort of like, you just sort of know it when you see it kind of thing. I think we owe it to ourselves, we owe it to our trainees, and we owe it most importantly to our patients to be able to say, this person is getting better and here's what we're doing to make them better, because our patients deserve us to be better at what we do every day. So
absolutely. And I think that in the framework of equity and justice, these things that are really important to us in this sort of next generation of OBGYN training, it's really important to recognize that not every OBGYN trainee has to end at the exact same. There's no question that there's some minimum amount of competence that should be required of trainees. But recognizing, just as I saw in my own colleagues, that not all of them want to take this to the nth level. Giving them that opportunity is more important than anything. And that's really what I see as the equity aspect. We are going to give not just the fish, but we're going to give the lessons on how to fish that are going to give everybody the opportunity to grow in this field if they want to grow. And we owe them to do that in all domains of obstetrics and gynecology, but I'm obviously most passionate about the surgery.
Well, clearly it's not something that's limited to surgery, but you've certainly given me a lot to think about. And I think you've given our listeners a lot to sort of take back, and whether we're in academic settings or private practice, whether we're with trainees or just with ourselves, I think this perspective on learning how to learn is extremely valuable. Thank you for spending so much time thinking about this stuff, for doing this in your career and making this such a passion of yours to allow those of us who need a little extra help to learn more how to do that. So it's been an absolute pleasure, Arpit. I know you're busy and taking up a bunch of your time, but I'm grateful that you've joined us. I'm grateful that you've been a part of the show, and we look forward to having you back on once you can tell us all the ways that you can measure when you and Veronica get together and solve this problem. We'll be glad to have you both back on.
Mark, thank you so much. I really appreciate the opportunity, and I'm super excited about surgical education. And I'll tell you, if you listen to this podcast and you're excited about it with me, come over and do our fellowship at Penn State Health in Hershey. It's a fabulous fellowship program, and we'd be happy to have you if you're a resident listening. And if you're a fellow and you want to talk more about how to maximize your education as a trainee, we're happy to have those conversations offline as well. And I am absolutely looking for motivated educators to partner with to develop this kind of work, because ultimately I'm not the best at this. I don't think I'm anywhere close to that. And there are real giants out there. And then the more we put our heads together, the better we get to serve our patients. So I'm looking forward to that. And I certainly hope to get to chat with you some more. I'll see you hopefully at SGS or maybe AEGL next year. But certainly if you come back through Hershey, don't forget to stop by.
Yeah, like we discussed a little bit before we started, the most important thing for anybody who's considering training with you is that the chocolate store is across the street from the hospital for the most part. It's like right there.
That's correct. Absolutely.
Make your own candy bar every single day, I think is something that you just need to understand is not something you get at every single fellowship institution. So
that's true. And you know what? They're building a brand new Hershey factory, and they're going to make the Hershey chocolate bars here again. So it's all going to be made in America right here in Hershey. And you can, come for the surgery and stay for the delicious smell of chocolate.
Well, absolute pleasure. Great seeing you. And thanks again for spending your time with us on BackTable.
Thank you so much. Y'all have a good one.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgoginski.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.